Morning, I'm Stacy Dunn, I'm the stroke doctor. So first of all, thank you for inviting neurologists to the cardiology party. Felt very honored to be asked to speak today. Maybe wondering my brain doctor is at a heart party, so that's what I hope to explain to you today. I am co-director of the UC stroke team, and I also help to run the vascular neurology division here at UC Health. And so I'm excited to give you my purview on how I can intertwine or intersect with patients with atrial fibrillation. Before we do that, let's orient you a little bit away from the heart. We'll move up to the brain just to give you a little bit of background and talk a little bit about stroke, because that's how the two are connected. I'll start by saying stroke is a preventable emergency. It is a leading cause of disability in the United States and worldwide. But like I said, it's preventable, so this is the good news. And today we'll focus on how that abnormal stroke rhythm we keep hearing about, atrial fibrillation or AFib, also for the sort of A-flutter, I heard a question about A-flutter, can cause a stroke, which is the scary part. But we're going to talk today about how we can lower that risk. So what is a stroke? This isn't a pop quiz for you, I'll teach you. The pop quiz comes later. There is actually two kinds, major kinds of stroke break it into two branch points. One is an ischemic stroke. That's very similar actually to what happens with a heart attack. It's when a blood vessel carrying blood cells and oxygen to the brain gets blocked up, and so the brain can't get the blood and oxygen that it needs. There's another type of stroke that's called a hemorrhagic stroke. That's a big word for a bleeding kind of stroke. And that's actually where an artery ruptures and blood actually flows into the brain, also causing problems. Obviously, the brain needs oxygen. We're very reliant on oxygen and glucose to be able to think and move and see. And so without it, brain cells begin dying within minutes. When this happens, our goal as a stroke neurologist is to get that open as quickly as possible. I would be remiss without telling you the signs and symptoms of stroke before I finish the rest of this talk. And you might be interested to know that this acronym was born out of Cincinnati and is now used worldwide. This FAST, now Be Fast acronym. So if you take away one thing today, it might be this: signs and symptoms of stroke. So the Be Fast acronym, the B stands for balance, E stands for eyes, vision deficit, F, facial droop, A is arm weakness, S is speech, and that can be slurred speech or difficulty getting words out or understanding language. The T is time to call 911. And all of these, when it happens with a stroke, are sudden in onset, very similar to a heart attack in that you're going about your day and all of a sudden everything changes for you. The key point is to get to the hospital. Don't wait for things to get better. Don't call your family doctor or your friend or your significant other. If you can call 911 or someone to call 911 for you, the quicker you get to the hospital, the more options you have for us to treat you and get that blocked artery open, which is the goal, as I mentioned. So be fast is what I would like you to remember today. So in a stroke, then, where can clots come from? There's actually a couple of different places. One is that clots can actually form the vessels themselves in the arteries right local in the brain. Other times clots can come from the arteries in our neck. You may have had carotid ultrasounds of your neck or other types of vessel imaging. Your doctors are looking for narrowing or blockages. Sometimes those clots then can travel up to stroke. The other place important to today is they can come from the heart, especially in patients with atrial fibrillation. There are other causes, but they're much rarer. In fact, atrial fibrillation is probably a third to maybe a little bit more of all cause of all stroke. So very important in my role as a neurologist. We have clues to tell us when a stroke or when a clot may come from the heart and cause a stroke. In AFib, we just learned that the heart beats irregularly. That marching band picture was so well depicting that the heart just isn't synchronous, right? And when blood is not flowing right, it tends to pool in the heart. That causes the clots to form. Then when the heart beats, those clots can go out to the body, but they can go up an artery to the brain. And that's what causes the stroke from atrial fibrillation. When we look at this on a brain image that I'm showing here, this is an MRI image of the brain. You might be able to see those scattered white dots. Those are all areas of ischemia or stroke, where the brain's not getting enough oxygen. And when we see it scattered like that throughout the brain, that is a big clue that this came from the heart, not from one specific type. So this is what I would see and say, if we don't know that you have atrial fibrillation, you're going to look really hard for it to prevent more strokes in the future and to get you hooked up with a cardiologist. I hear this a lot from patients because I'm often seeing the cart before the horse, the opposite of what would normally happen. People would say, wouldn't I know if I had atrial fibrillation? And quite honestly, from my purview, we often diagnose it after the stroke. There aren't always symptoms of atrial fibrillation, especially if that rate is controlled. So although your heart could be beating irregularly, you may not feel symptoms. We only find it when we look for it. And it's already mentioned, we have multiple ways to look for atrial fibrillation with different kinds of heart monitors. Some that sit on the chest and monitor that electricity, others that we can actually implant under the skin. Those actually can stay there, hanging out for about 3 years. It's the last that I know, unless things have changed, and about that time the battery wears out. But we can look very minimally invasively for heart rhythm issues for up to 3 years. And a lot of times after someone does have a stroke, this will be something that I would do as a neurologist. If we found AFib, then we would send them to a cardiologist for further management. But the whole idea is to find it so that we can prevent more strokes. We know that detection increases over time. So the longer we monitor, the more AFib we find. Very early after a stroke, we will find AFib about 5 or 10% of the time. But as we monitor and as you go out to a year, that detection can go up to 30%. So that's why for us it's important to, especially when we see a stroke indicative of atrial fibrillation, we look very hard for it. We'll look for several years if we need to. I'm sure you can't get throughout the day today to learn about, and I've already heard it mentioned once, Chad's VAS scoring. What that is telling us is that atrial fibrillation, along with other medical risk factors that you may have, they add up. They add up to increase your risk of stroke from AFib. And without going into detail, some of those things that Chad's VAS acronym stands for are listed here. Things like heart failure, hypertension is a big one, diabetes, prior stroke, or vascular disease in other vessels. All of these things, the more risk factors you have, the higher your risk of stroke when you have atrial fibrillation. So when you have 5, if your Chad's VAS score is 5 or more, that risk is about 10% per year. So what are we going to do about that? Luckily, in the age of modern medicine, we have some ideas. So how do we lower that stroke risk when AFib is found? So in most cases, as we mentioned, our go-to is blood thinners. And we used to use warfarin, sometimes we still do. There's other options available that don't need as frequent monitoring. As mentioned, these medicines don't actually change the electrical activity or change the AFib itself, but they prevent the clots forming when the heart is beating irregularly, and thus prevents stroke. The relative risk reduction is quite profound, 60 to 70%. I'm going to show you this in a chart, how profound it is when we give patients, when we find AFib blood thinners, at lowering their risk of stroke. Again, mentioned, and you will hear about later today, some people can't tolerate blood thinners or have other medical problems that preclude them from being on blood thinners, like a bleeding issue and a clotting issue at the same time, where you might be referred for a procedure to help control the atrial fibrillation or even a surgery. So there are options available again to control the AFib, but also lower that risk of stroke when you do have AFib. So here's a chart, and I'll show you in the next slide in a figure. When you're on a blood thinner, that's the third column, it substantially lowers that risk. So I showed you the first 2 columns already, so that risk can go up to 10% if you have 5 or more of those other risk factors along with AFib. So you look at that 5+ row at the very bottom, those are our highest risk patients. When they take a blood thinner, Eliquis, Xarelto, Pradaxa, blood thinner, We lower that risk to about 3 to 3.5% per year. So it's not perfect, it's not zero, but it greatly reduces to about 70% your risk of stroke just by taking that blood thinner. And of course, there's other things you can do as well. As promised, here's a chart. I like pictures. So showing you that risk of stroke without anticoagulation. That's a big word for blood thinner. Without a blood thinner, your risk is shown in the red bars, and it goes up quite substantially, as we mentioned, up to 10% per year. As those risks, as if you're on a blood thinner, then that's the white bars, you can see that risk is lowered in each one of these categories. Does that make sense? Again, there's other things you can do. Medicines are great, but let's think about all these other things we can do too. We want to make sure, again, blood pressure control. So blood pressure is the #1 cause for stroke overall. It's also a risk factor for atrial fibrillation. So controlling blood pressure becomes so important when you have other things going on. Now you can work on that for days. Knowing your numbers, knowing what your blood pressures are and what your goals are, and working with your primary care doctors and your cardiologist to get your blood pressure well controlled. As mentioned, we have many medications to choose from. It's probably, in my mind, besides the blood thinner, the most important thing to do. Also, lifestyle things, smoking cessation, healthy diet, exercise, and we often, almost always, pair a blood thinner with a statin. Statin does lower cholesterol, but it also lowers stroke risk overall. So my patients who have had strokes are often on a blood thinner, they have AFib and a statin. Those things alone greatly, again, reduce the risk of stroke. And that really just takes me to this final slide, and my take-home message was, how do we connect, how does the heart connect to the brain? Atrial fibrillation, which we're all here to learn about today. When that happens, the heart beats irregularly, the blood doesn't flow real nicely, begins to pool, and clots form in the heart. And then one good squeeze, and one of those clots can go up from an artery and stop blood from getting to the brain, and that's what causes an ischemic stroke. Luckily, we have lots of options to reduce that risk, including anticoagulation, controlling other risk factors, and lifestyle modification, and we can greatly reduce that risk. So I will stop there, but I am happy to answer questions from my perspective. Yeah.
What about the Watchman?
Yeah, sure. I will not talk about the Watchman. That's not my specific area of expertise. But this is, so as I mentioned, not everybody can tolerate anticoagulation or blood thinning, right? For various different reasons. So a Watchman would be a procedure that one can get to block clots in a different way, right? So that would preclude you, that would mean you wouldn't have to be on blood thinners the rest of your life if you get a Watchman device and prevent those clots from moving out of the heart. But we don't hear more about that.
So I have one from online. Do you consider baby aspirins a blood thinner? For example, my dosage is the 0.81 3 times a week.
Yep. So aspirin is not a blood. It does thin the blood a little bit, but in this context, I do not consider it a blood thinner. I can use better words. So aspirin, in my world, I would call it an antiplatelet. So it's good for stroke prevention in many reasons, especially if there's plaque in the arteries, either in the neck or the brain. And aspirin keeps the blood flowing nicely. If you're often with people with heart disease and strokes, they'll be on an aspirin for stroke or heart attack prevention. But it keeps the platelets from sticking to the wall of the arteries, and that's how it prevents strokes and heart attack. Blood thinners, anticoagulation, in other words, things like warfarin or Coumadin, Xarelto, Eliquis, Pradaxa, those actually keep clots from forming. So it's a different mechanism for stroke prevention, and the one that we use for atrial fibrillation. So aspirin doesn't greatly reduce your risk of stroke if you have AFib. You would want a blood thinner. Thanks. Any other questions about the brain? Because I can't answer the ones about the heart.
Say for instance, people have MS, or in my situation, I have sulfoidosis, and And like I said before, my AFib was discovered when I was doing another surgery. And I had high blood pressure. So you were talking about mitigating the risk of stroke. So the course for me would be to go on eloquence, keeping the high blood pressure under control.
That's exactly
That's
right.
the main thing.
That. Learn something. Yes, that's wonderful. Yeah, so the question is, many of us have many medical things going on and things interacting. There's other neurological conditions, right, that can cause weakness and numbness that don't change your risk of stroke. Going back to the stroke risk factors, the AFib, right, the Eliquis is perfect to lower your risk, and then controlling those other risk factors. As you mentioned, hypertension being, in my mind, the most important. And then things like smoking, controlling diabetes, exercise, and diet. Those are the things you need to do to lower the risk of stroke, independent of everything else going on. Yeah, you're doing so good. You're here.
You could, on your presentation, you said you could reverse that AFib that you had for a long time. How could we reverse it? You get back to normal rhythm.
See, now you're bringing me back to a hard question. I'm a brain doctor. So I think we're gonna learn ways about controlling the AFib, and keeping it at bay. I think there's probably several different ways to do that. My job, brain doctor, isn't to change the AFib, but for my patients who have AFib is to prevent stroke. I have no idea how to stop the AFib. Thank you very much.